I appreciate the opportunity to be here, to have been invited to talk with you about privacy. I'll just tell you a little bit about our organization. First of all, I'm a registered nurse. I used to work in the children's emergency room in St. Paul, and then I moved into school nursing. And then I started watching what the Clintons wanted to do with healthcare and became very concerned and started an organization after the Clintons were done, but realizing that in Minnesota we had the Clinton system here, and then eventually realizing that everything comes from DC no matter where you're at. So we're now a national organization located here working during the legislative session in Minnesota, and outside of the legislative session we help other states stop their Obamacare initiatives and go to DC, et cetera. So the mission of our organization is to support patient and doctor freedom, medical innovation, and the right of citizens to a confidential patient-doctor relationship. And what you'll realize in this, which I think a lot of you probably realize already, is that the only way you can have freedom is to have patient and doctor control over the data so that the government cannot have control. I'm going to start with just two things so that you know. If you go to our website, cchfreedom.org, and you have documents, so it's on there. But we have an e-news that's every Wednesday, comes out every Wednesday with a commentary by me, and it's about more than privacy. It's about the whole, everything that's happening in healthcare, including some of the ethical issues that I think a lot of the public doesn't understand. Okay, so on the basis of privacy, he who holds the data makes the rules. That's what I say. He who holds the data makes the rules. And so when it comes to freedom in healthcare, if you don't have protection of the privacy and the confidentiality that patients need and that doctors need, you can't have freedom. As soon as the government gets control of the data, they have the control. So he who holds the data makes the rules. Now I'm going to talk with you about the privacy pieces of Obamacare rather quickly, but before that, I listened to one of the questions in the Q&A, you know, about payment, and I want you just to know that I pay cash all the time. And that's the only way that I pay because, one, I don't want a record, and I know what they're doing, and I don't want them to have a record of me. But the other thing is I really want to be in the system to see what it's like to pay cash, to be an example of what it's like to pay cash, to be able to tell people I do it all the time and I negotiate. So here's a story. I had some moles taken off of my face, and the doctor, I said, so I'm going to pay cash. So how much is that? And whatever it is, I would like a discounted rate because I'm going to pay cash. And he said, I don't know what that is. I said, well, can you find out what that is? He goes, okay. He goes out to the billing office, comes back, and he goes, well, it's like $150, so will $120 do? I thought, oh no, he said, so is $120 fair? I thought, well, probably not, but go ahead. And so I didn't say that. I just said, okay. And then takes the mole off, comes back in to give me my discharge. And I said to him, so what does Blue Cross Blue Shield pay you? He goes, I don't know. I said, well, how about if I pay you $90? He goes, okay. So, you know, the people are really afraid of paying cash because they don't understand cash and they just think it's more expensive than it is. So now, about privacy. The Obamacare is just replete with invasions of privacy, intrusions into the medical practice, intrusions into the patient's medical records. So here, what I provided for you were 10 things to know about privacy. So that's one of the brochures that you have. But even that brochure doesn't include the health insurance exchange, which is the greatest invasion of all because it took us a while to figure out because we didn't know about the hub. And so I will talk about that in a second here. But just to be clear, when it comes to the ACA, doctors, hospitals, et cetera, have to report treatment and outcomes data. They have to use electronic medical records, and I don't know what you know about them. We don't have any problem with electronic health records if the health record is being used within the place that the patient is going, so within the clinic, within the hospital, but then the patient gets to decide if that data goes outside of that. But that's not where we're at today. We have HIPAA, which says that the patient has no choice over what happens to their medical records. And so you see in the second piece of the flyer of the documentation that I gave you is some truth about HIPAA, because we encourage people never to sign the form. So I hope that in your offices you never mandate that anybody has to sign the form. HHS actually has on their website now that you don't have to sign the form. So let's help get patients to understand that HIPAA has nothing to do with privacy and everything to do with opening the medical record to the government and everyone else. And so the electronic medical record, HIPAA, because of HIPAA, we have the electronic health record and we have government access to it. And so with HIPAA, together with high tech, the government says 2.2 million entities have access to your medical records without your consent. 2.2 million, it's in a regulation. So, that's countless people, 2.2 million entities. Okay, and then the ACO, you talked about the ACO. So it's really important. I was telling some people at lunch that I was talking to a lobbyist who was trying to get the ACO language passed here in Minnesota. And I was asking the lobbyist exactly how it worked, because he was from a health plan and the other one was from a medical center. And so essentially how it was going to work is that the health plan was going to get all the money, all the premiums from the government, et cetera. And then they were going to keep 15% and then give the 85% to the ACO. And the ACO got to, become the insurance company in essence. And then what the health plan would do is they would take their 15%, which was handy for the medical loss ratio to have that perfect little percentage there. They would take their 15% and it would be their job to track the patients on behalf of the ACO. So they would lose their insurance status and become the trackers. And that was how it was going to work. And so when you think about where healthcare is going, and you can see that Obamacare wants the ACO and the exchanges to work together, then what you see is that the health plan is gone. The health plan becomes the data center with tracking patients around the country, and they become the transfer of the money. But really the insurance is gone, and now it becomes the ACO, the doctors and the hospitals and the clinics that become the insurance companies and take on all the risk. And so the tracking has to happen of where they are in order to try and keep all the money within the ACO. There's health plan reporting, a lot of different places where there's health plan reporting. There's IPAB and PCORI. PCORI is a Patient-Centered Outcomes Research Institute, which is going to get information. They are allowed to request from hospitals, doctors, and insurers information in order to conduct research. The Secretary of Health and Human Services then uses this research to decide what are essential health benefits, as well as to inform IPAB, the Independent Payment Advisory Board, which has supra-legislative authority. In other words, they make decisions about what Medicare will pay for and what it will not pay for, and then those decisions happen. They're implemented immediately, and then Congress, if they can get a supermajority together, can decide to undo that decision. But essentially, IPAB just moves forward, and they don't need any kind of vote whatsoever from Congress to make those decisions about payment cuts or payment denials. There's something called the National Strategy for Quality, and it allows data to be collected on the health and functionality of patients, on doctors' resource use, and on quality and efficiency. There's tracking of doctors and their free drug samples, which doctors provide them, how many are provided, et cetera. There's the new pre-Medicare screening for patients who are between 55 and 64. And we believe that any of that data then goes to the federal government. There are a whole bunch of new registries, new government registries. There's something called Elder Justice. And Elder Justice is a reporting of clinical data from the long-term care facilities and people who take care of seniors. There's the free wellness visit for seniors, which we actually call more of an assessment of how much of a risk the senior is going to be. And then there's the exchange, and this is not a limit. This is not a complete list of all the data and all the privacy violations in the law, but it's a good start. Let's just put it that way. So the exchange is really the largest I just need to explain it to you for those who don't understand, and I understand lots of people don't, and we have become a resource from around the country to understand what the exchange is, probably because Governor Pawlenty tried to put it in 2007, 2008, and we stopped it then, and then there were 2 more years that we stopped it, but then now we haven't been able to stop it in Minnesota. But during that time, we got able to figure out what it was. So we eventually put a diagram together, and I think you have that diagram in your packet of what the exchange is. It is essentially 5 different pieces if it's a state exchange, 4 different pieces if it's a federal exchange. The big thing to know, if you have that, I'm going to make sure you do. Let me just make sure. Yeah, here it is, this thing. The big thing to understand about the exchange is it's a national exchange. There's really no such thing as a state exchange or a federal exchange. It's all a national exchange. I like to describe it as the central server and the 50 dummy terminals. So the central server is the Federal Data Services Hub, and that's one piece of the exchange, and it's right there in the center. And then stretching out to the states is the second piece, which is the complete computerized network that connects the states with the exchange and the federal government with the exchange and the health plans with the exchange. The third piece of it is the 50 dummy terminals, which are either going to be funded by the federal government or the state government, and that's what they mean by state exchange versus federal. It's a matter of who is funding the dummy terminal and keeping the IT connections going, but it's all a national system. And then the fourth piece is not on there, but it is called the Health Insurance Exchange Program. And it is a new federal system of records, or in more normal terms, it's a brand new centralized database. So if you look at that process that we have on that sheet of paper, you'll see at the far left that there's a person who goes onto their computer, and they are going to apply for coverage on the exchange. And so they put in some data that's on a federal application form. And on that, and it includes things like, you know, their name, their demographics, whether they're part of an Indian tribe, where do they work, how much do they make, do they get insurance from work, etc. They put all that information in, and then they go send. And when they go send, it pings the Federal Data Services Hub. And then the hub goes out into state agencies to try and verify that this person is who they say they are, according to this information that comes from the person versus the state. Then they also it goes out into the federal government, and it gathers information on their citizenship, on their social security number, on their criminalization history, what's their tax status with the IRS. So it goes out and grabs all of this. And now all of that could just disappear once the decision had been made whether or not they could get coverage through the exchange and whether or not they could get a subsidy through the exchange. But it doesn't disappear. It goes into the Health Insurance Exchange Program, this new database. And this database will not only have information on individuals, it'll have information on employers and employees, navigators, brokers, in-person assisters, federal contractors, state contractors, and anybody, and all the different state and federal employees that are part of the exchange. So it is, as some people said, it's the largest database being created in the history of this country. This is indeed the largest IT system being created. They aren't even sure they can pull their act together to pull it off, and we can hope that they don't. But they're going to try really hard, because the exchange is the implementation center for Obamacare, or we call it the Federal Takeover Center, or you can call it the Wealth Redistribution Center. It is many things, but it is the apparatus for national health care. And so this is why our organization has a Refuse to Enroll campaign, which is a flyer that I've distributed and which has gotten some national press, because we understand that if the exchange fails because it can't be financially viable, because there's not enough people in it, not enough money in it, then Obamacare cannot be implemented. So this exchange is the largest data transfer system in this country, and it is a violation of all our privacy rights. And even liberals are a little bit concerned about all this data and what's going to happen to this data and how this data will be used. We have reasons to say no to the health insurance exchange, which you see in the flyer. and we say 4 things about it which are really important, which I hope that you might have this flyer in your office, because what's going to happen is that the federal government is giving out millions and millions and millions of dollars. They're giving out millions of dollars for outreach. They're giving out millions of dollars for marketing. They're giving out millions of dollars for navigators to go into different places and try and sign people up and tell them how wonderful the exchange is. And so Blue Cross Blue Shield is giving money. Planned Parenthood has given $14 million to the Enroll America. Enroll America comes out of the Obama administration, former staffers of the Obama administration, and they're going to go around and do meetings all around the country trying to enroll people into the exchange, because they understand too that if the exchange fails, then Obamacare fails. And so the 4 reasons to say no to the exchange in particular are because of this huge privacy loss, but also because the premiums are going to be very expensive as the wealth is transferred from the young and healthy to those who are high risk or have pre-existing conditions, because this is where those folks are going to come. In addition to that, I mentioned the privacy piece, and then the fact that this is not private insurance. Now, I was just talking to a reporter yesterday because we just put up a sign outside the Minnesota State Fair that says, it has a woman and she's like this, and she's like, why can't I choose my own doctor? And then it says refuseminsure.com. And so she was asking, I said, well, this is not private insurance. And she goes, what do you mean it's not private insurance? I said, it's not private insurance. You are applying to the federal government under penalty of perjury. And the only way you get any coverage is through this intrusive application form and to the federal government, and then whoever they contracted with is who you get to choose from according to whatever requirements that those companies have to have. And just like Medicaid today, you know, the Medicaid person today comes with a Blue Cross Blue Shield card, but they're on Medicaid. So this is we call it Medicaid for the middle class. That's what exchange coverage is, and we hope that doctors will refuse it just the same way that they do traditional Medicaid, and will help their patients to understand that they're not getting private insurance, they're actually getting government health care. So an interesting thing about the hub, the Federal Data Services Hub, which is, it's, you know, I kind of see it like a spider, many legs going out and gathering data, right? In testimony about 2 weeks ago, one of the members of Congress asked the CIO, the chief, why can't I think of the I? Thank you, this chief information officer. So where exactly in the law is the hub? And they're like, well, it's not exactly in the law. It's just this concept that we came up with for all the communication that has to happen through the law. So the hub actually isn't legal per se. It's a regulatory entity that is being established. One other thing I just want to say about the information is, and you all know this, the 140,000 CPT codes. Well, I look at this, I mean, you're probably looking at this as an administrative snafu, right? But I look at this as intrusive, because if you've, as they say, gone into a lamppost, it says that you have run into a lamppost. And if you run into the lamppost again, it says you've done it again. And if it happens to be by an opera house, that's what it's going to say, by an opera house. And if you happen to run into the chair in your bathroom, it's going to say furniture in your bathroom. It's not just going to say in your home. It's going to say which room in your home. And so I think that the codes are about intrusion. I think the codes are about tracking down to the last little detail, everything, and so that they will have such an incredible record of who you are. They can use your medical record to profile you. They can use the medical record to profile the physician. So when I look at, you know, what you can do, I say talk to your state legislators and tell them, write a law that says consent is required, because the fact of the matter is HIPAA says any state legislature that does a stronger law, that's the law that has to be followed. So if patient consent is required in your state, That's what has to be required, and all that data cannot go anymore to 2.2 million entities. Your state legislators have to do that. Another thing you can do is you can refuse to do the electronic health record. I know Keith Smith in the surgical center in Oklahoma has said they're not having electronic medical records because they're going to protect privacy. If you're an individual doctor, don't do it. I did hear that it was better for one doctor, and so then do it, but don't connect. Don't connect outside of the office. Refuse to enroll as a exchange provider. Tell your patients why they should refuse to enroll in the exchange. And then refuse to don't even have the HIPAA form, or have the HIPAA form and write on it, say, you don't have to sign this. And please do not include it in the consent for treatment. I can tell you that I have had a patient call me who said, I refuse to sign the HIPAA form, just like you said. And I went in to have my, labor, delivery, the surgery to have the baby. Why can't I think of that? C-section. All I could think of was CAT scan. She said, I went in to have my C-section and I refused to sign it and they sent me home. I said, okay, go take care of yourself and your baby and we can deal with that later. But they had combined the treatment with the form on HIPAA. And so she didn't have any choice. So please don't do that. And then I can just say that privacy is key to function. Key to freedom. Without privacy, there is no freedom. And every socialist country knows that, every communist country knows that, every tyrant knows that. That's why there are spies on people in like Stalin's time, right? You have to collect data on people to have control over them. So please be part of the solution and understand how much the data is there to control your practice and to profile you and to profile your patients and to deny your patients access to the care that they need. So thank you very much for listening.
I have sometimes I don't enjoy the obligation I have to explain MNsure, the exchange, to the general public. And it's interesting, in MNsure's slide, they show over here the clients, and they show here, the agents and so forth, and the carriers are up here, and the state, they have 4 different state government offices, and down here is this little thing that says hub. Federal tax hub, or federal hub. Just a little thing, kind of innocuous, right? Well, I changed their slide just a little bit. I have these little lines that go out from it to all these agencies. And I've got to tell you, Twyla, I'm going to add some more lines now, so thank you so much. I think that's purposeful. When state exchanges are preparing to go out, or federal, they spend a lot of money on ascertaining what the people want to hear and the words that work. That's why they changed it from exchange to marketplace. They don't call it exchange anymore. Okay, I'm done. Been waiting for this for, well, a long time. A couple of years ago, I said, AAPS, you got to come up to Minnesota and do one of these. Here we are today. I had the great pleasure of interviewing Dr. Orient in the early 90s, and it's a particular pleasure for me to do the real quick introduction to the executive director of the American Association, the Association of American Physicians and Surgeons, if I ever get it right. And what a great job you've done. Thank you so much. Please welcome Dr. Jane Orient.
Well, Dave, it's my pleasure to be here, and it's always such an inspiration for me to hear these wonderful doctors telling about the innovative, the creative, the original, and the very courageous things that they're doing to do things right. APS is about promoting the practice of private medicine. That means, according to the oath of Hippocrates, to do the best for my patients according to my ability and judgment. That is medicine. What we have today is deliberately called healthcare, which means serving somebody else to provide some political, social agenda for maybe optimizing the population health. So many physicians have traded in their freedom and their professionalism in return for what they see as security. And in lack of freedom, there is no security. So one thing AAPS does is try to encourage people to do the right thing and to bring them examples of people who are doing it. But the other is to warn them and to the extent that we can defend physicians who are up against some extreme threats to their professionalism and their liberty. Physicians think, oh, well, we'll just go to work for somebody and then maybe we'll be okay, like the hospitals or like the government under Obamacare. These are not our friends. I'll tell you about like 2 cases today. One of them is a physician that I interviewed for the last issue of the journal, a physician who underwent the sham peer review procedure by his hospital, in which their biggest weapon these days is called the disruptive physician. He was considered disruptive. He can't tell me or can't allow me to publish very much because he's undergoing rehab now. He's got a couple years away from his family, working in this hospital, serving them and trying to show that his thinking he's recovering, that his thinking has been corrected, and he can't really advocate too much for his patients lest he cause disruption. And he referred me to a book called Life and Death in Shanghai by Nian Cheng, a woman who survived the Great Cultural Revolution in China, was imprisoned in solitary confinement for more than 6 years in People's Detention Center No. 1, because this physician told me, this is like what I endured during this process, this mandatory so-called psychiatric reevaluation or physician evaluation things paid for by himself at great expense, involving things just like Mrs. Cheng was describing, these struggle sessions, this pressure to confess over and over again. It's pressure to try to get her to incriminate other people. And the reason they put her through this is because their purpose was to reform people, to make them really think correctly, like communists are supposed to think. And it's really quite disturbing that the American academics and American medicine kind of accept this process, which is like what the Chinese communists used. Reminds me during my early career, I was a VA physician, and I have to identify with Dr. Elkema said about the monthly meeting and the monthly fights. Except one of our nurse practitioners had the brilliant idea, let's just go to the monthly meeting with a tape recorder. And then next month, we'll play the tape, and we'll go off to the canteen and have coffee, and the result will be exactly the same. Fortunately, I got out of there. But during this time, in 1978, I read this article in the Annals of Internal Medicine called A Marxist View of Medical Care, which I think reflects thinking that is so pervasive in the American medical establishment that we don't even recognize it now. They did speak something about the Cultural Revolution. They did recognize that it destroyed the careers of many physicians. It smashed medical education, but there was kind of a positive spin on it. It made it more egalitarian, so that, the doctors could be more like the mid-level practitioners, and you learn to be a doctor by being a doctor, and so on. And they never ever mentioned the tens of millions of people who died, most of them because they starved to death, but many of them because they were actually killed. I'd like to read to you just a little bit of what the Chinese communists themselves said during that period. We would rather have socialism's lower production figures than capitalism's higher production figures. The radicals in the rural area took this up and said, we would rather have socialism's poor harvests than capitalism's abundance. Not to be left behind, other radicals declared, we would rather have socialism's trains that are behind schedule than capitalism trains that are on time. In such an atmosphere, the workers became fearful of doing too much. The peasants became reluctant to go into the fields, and drivers of trains, buses, and even mules slowed down so they could be behind schedule. So even the socialists know that socialism doesn't work. The Chinese, of course, learned something from this. Doesn't seem like the Americans have yet. But they supported it because they felt this is morally right, that socialism is morally right. And I think that we need to speak not just about capitalism's undisputed advantages in bringing prosperity to all, but the moral case for capitalism. I think the moral case is this: freedom is good, slavery is wrong. Slavery is evil, theft is wrong. We do not need to apologize for being for freedom of enterprise and our freedom to act in our patients' best interests. In fact, if we are participating in this system of wealth redistribution, which is what Obamacare is all about, are we not accomplices? Are we not collaborating in the crime of theft and in the crime of diminishing the quality of medical care available to our patients? Well, you know what? Who's going to be blamed for all of the problems that are undoubtedly going to result? We are. And to the extent that we take their money, are we not complicit? Are we not also guilty? Well, 2 days ago, I had the honor of having dinner with Dr. Natali. Dr. Harris showed you a picture of Dr. Natali. APS has known of many physicians who have been harassed, persecuted, and convicted and imprisoned because of Medicare. Dr. Natali was actually acquitted of Medicare fraud, but he was convicted of making mistakes in his operative reports. He was certainly one of the most productive cardiovascular surgeons in the area around Chicago. If you think he was a greedy fat cat capitalist, well, he was the only cardiovascular surgeon who would take public aid patients. He was on call 365 days a year for the poor people because none of the other surgeons wanted to take care of them. He worked from early in the morning until late at night. He got behind on his dictations and he made some mistakes. Well, mistakes are now a crime, even if you didn't intend to make the mistakes. They assume, well, if you're a good doctor, you wouldn't have made that mistake unless you intended to. You must have been, the only motive we can think of is that you wanted to pad their bill. And the judge was making this case in the sentencing memorandum and saying, we have got to send a message to those doctors about the need to comply with all of these regulations. So they went through, he was in practice for about 35 years. He'll never do medicine again. They found 5 cases to prosecute him on after reviewing thousands of records. These 5 cases were 5 elderly, very complicated patients who had ruptured aortic aneurysms and whose lives he saved. They all did well after surgery, but now he is a convicted felon. He's doing the last month of his term on home confinement. His wife asks him, where's your cell phone, John? Because if he doesn't answer his cell phone when they call, back to prison he goes. Imagine a physician being treated this way. I went to the appeals hearing in the circuit court in Chicago, and the prosecution admitted, and all the judges seemed to agree, that the instructions given to the jury were wrong. They would never use these instructions again. They were unjust. They didn't tell the jury that if you're going to convict him of something, it has to be related, it has to be material in some way to the charge of fraud. There was no underlying fraud. He was acquitted of that. And the errors in the operative reports had absolutely nothing to do with the billing. They were in a report that possibly nobody except a prosecutor or a malpractice lawyer would ever actually read. But the fact that these wrong instructions were given and admitted to was considered a harmless error. And so his conviction was upheld. The judge and the prosecutors can make an error that destroys a physician's life and deprives patient in this wide area of one of their most productive surgeons. That's a harmless error. But the doctor cannot make a mistake in describing an operation while he's dictating piles of 100 charts. This is a very serious thing, and we hope that even the AMA might eventually get involved in this one, although unfortunately the AMA in the past has actually advocated that we have junkyard dogs and the Department of Justice to root out all of these bad apples among the doctors to protect the public fisc, to protect the Medicare program against doctors. So Our suggestion to physicians, whenever any of these new regulations comes along, or whenever one of these cases comes up, is don't take their money. Back when I was in junior high school, there was a big discussion going on about federal aid to education. You can tell I must be pretty old, that's a long time ago. And my 7th grade math teacher was telling my mother, if you take their money, they'll tell you how wide to make the door. Of course, they will also tell you everything else about how you're supposed to treat the patient, about what you're supposed to record in the chart, about what kind of codes you have to fill out, and on and on and on. And then I learned from a plumbing contractor, Russ Plumbing, that used to do some subcontracting from my dad, who was a general contractor, that if you take their money, they'll tell you how much you're allowed to earn. Russ had done a job for the government. He was the low bidder. He did the job at the price that was quoted and without any problems. But years later, the government came back and said, you made too much money. And not only did you make too much money on what you did for us, we're going to investigate everything you did for everybody else, even your private contracts. Like your private patients could be, they have the right to audit even the records of your private non-Medicare patients if you take their money. And so they ruined Russ's plumbing business just by the audit alone, and then he had to give refunds to all of these contractors where he had done the job, set at the price that had been agreed upon. And then if you take their money, they can send you to prison. Dr. Natali said he met some of the nicest people he'd ever met at Oxford at the correctional institution. Some of them were there for 5 years, much longer, for things that, again, involved nothing that you would ever consider to be a crime. So I think what we need to do is we need to get out of the system. We owe that to our patients. We owe that to our families. Dr. Natali, fortunately, still has a beautiful home and a beautiful family. The reason he still has any assets is he protected them, that they were all in a trust in his wife's name. Some of the physicians I know who are in prison, they've lost their family, they've lost their home, they've lost their medical license, they've lost their cars, they've lost their life savings. They are finished. Most of them are older and they've been in practice for many, many years. They're good targets for the government because they have assets to help fund this bankrupt federal program. You know, they're running out of the money they can get from the taxpayers, but doctors are a possible source of funding. So getting out of these programs is, first of all, I think it's the honest, it's the ethical thing to do, it's the right thing for our patients, it's also the prudent thing to do to protect ourselves. One of my favorite scenes in the part 2 of Atlas Shrugged, the movie, was Hank Rearden. The government was deciding, after it had tried to destroy his Rearden steel or his Rearden metal by saying it was unsafe, all of a sudden they wanted a whole bunch of it, and they came and they wanted to buy it, and he said, I'm not going to sell it to you. And the government said, but you have to sell it to us, and we're paying for it. And he said, I'm not going to take your money. You've got all these troops, you've got all these weapons, come and take it. They said, but we're not thieves. But you see, if you don't take their money, it gives you a certain degree of protection. And you know it's very important to them to make you complicit in this system of destroying our freedom and destroying our practice of medicine. Sometimes they'll get discouraged when they see there aren't very many doctors doing that, although a Wall Street Journal article that featured our president, Jules Madrigal, did point out that we have 3 times as many doctors, or 4 times as many doctors opted out of Medicare now as we did back in 2004, which is still not very many. But, you know, exponential growth curves always start out that way. And we hope that will take off this way. Will enough doctors do it? Well, I don't know. And how many is enough? How many is a critical mass? Someone said, and I think it was Rabbi Lapin, pointed out that at the time of the Exodus, even though they had a leader like Moses, in all of those plagues in Egypt, only 20% of the people followed Moses, and the rest chose to stay in slavery in Egypt. So many of our colleagues are going to stay behind, but are you going to stay behind? Do you ever hear anything about the 80% who opted for transient security? Or are we going to lead the way into a promised land, potentially a new golden age of medicine, when we can leave behind some of the mistakes of the past and live up to the legacy that's been passed down to us. Okay? Thank you.
There you go. When I got out of the Air Force years ago, I thought I wanted to become a doctor. Now, after hearing this, I wish I would have. Then I could have opted out of Medicare and done all these wonderful things. It's been a great day. This morning I started out by telling you I had a brain bleed and what a difference my cash practice doctor made to me. I have to tell you the end of the story now. He's still doing well. I'm doing really well. I think you can tell I've healed pretty well. About 3 months after the ordeal, I call it my incarceration in the hospital, I had lunch with the charge nurse. And I said, tell me about this. You had me in care for 11 days in ICU, and seemed like it wasn't that big of a deal. Well, I guess it was a big deal. But she said this to me, and this is chilling. She said, Mr. Racer, you're 65 years old. You're in really good health otherwise. You've had a good, healthy life. We thought it was worth it. And I thought, okay, let's see, 75, 80, at what point is it that is no longer worth it? I don't want to hear that, you know, and I know that's not what you're about, and I know that's not what the doctors are about. We do have time for some more questions to either one of these two or myself. Not that I have anything to say. I can't see because of the light. There's someone up here. Okay. Okay.
Dr. Orient, it was brought up earlier in some of the off-time question and answer process. What about the new generation of physicians? We seem to be, all of us are talking about this, but we're kind of old for our constituency, that we have a group of young physicians coming along that maybe haven't had the same experiences, and they're not being taught in the medical schools and in their residency programs the value of the patient-physician relationship, and they don't get it when you talk to them about their obligations as physicians. The Hippocratic Oath that you began your talk with, I think, is being considered as outdated and not important. How would you suggest that we address that as kind of the old guard trying to protect our profession?
Well, this is extremely important, and what you say is certainly correct. The Oath of Hippocrates has been edited out of existence, and the doctors are being taught that their obligation is to society. One medical student that I talked to me recently said he was actually told by his professors that if you don't go along with the need to protect the treasury by going along with this end-of-life care, which I guess in Britain they call it the Livermore care or the Livermore death pathway, you're not going to be able to make a living. So these students are being immersed, probably up since kindergarten, in an ethic that is totally contrary to the ethic that we grew up under. And some of us think that they're just waiting for us all to die off. So I think we need to make every effort to get the message to the younger generation. By the way, if you know any medical students who might be receptive, we do have full scholarships, including travel and everything, to come to an AAPS meeting. Membership in AAPS is free. I can tell you the medical schools really discourage students from taking an interest in this.
Thank you. Okay.
Good afternoon. Talked about the moral high ground that opting out and having cash practice provides between the doctor and the patient. Can I ask you to please spend a minute or two on fleshing out on those bones some of those ideas that would reinforce that statement?
Well, if you were opted out, then you were working for your patient, and you are free to act according to the best advice that you can give, to charge what is a reasonable fee. You can forego the fee altogether if you want to. I think it's a very, very great mistake for people to say, oh, those concierge doctors or the doctors who are opting out, they're just going after the rich. Not so. As Dr. Madrigal told you, her patients are mostly middle class or poor people. They put some value on her services, and it really works just as it can work just as it used to when people were not dying in the streets. But patients were paying a reasonable fee for a service that they valued, and physicians were making every effort to make that affordable for them.
I just want to add something. I get lots of patients who call, or lots of people who call. And so I remember the one woman who called after she got her medical record from her doctor. And this was her doctor that she said, this is the doctor that when I'd see him, I'd go in and I'd hug him. It was 20 years or so. And she, her last appointment had been an appointment where it had been a really difficult day, a difficult day with her daughter and her son and the house and the dog and you name it. And she was just, talking like a normal person talks to a friend. And he said, well, maybe I should give you an antidepressant. She was like, what? I don't want an antidepressant. He goes, oh, here, I'll just write one out. You just take with you. She goes, I am not going to take an antidepressant. He said, just take it with you. Don't worry about it. You don't have to take it. You can tear it up. Just take it with you. So, several months later, she gets her medical record to take it to another doctor for some reason, and then she reads it. So she reads about her house and her dog and her son. And she reads all of this in her medical record, and she, of course, has antidepressant in her medical record. And she said, how do I get that out? I said, difficult. And I said, there's a protocol, a really strong protocol about depression. And here what you want is a patient-doctor relationship, right? But what you have there is a doctor who's following a protocol and then giving a patient a diagnosis that will follow her forever that isn't her diagnosis. And so when you talk about the moral implications, here's a woman who she doesn't know what to do now because this is now in her record.
What was the next?
Will there, this is for either, will there be some sort of disenrollment or opt-out process for the Obamacare exchanges? How do you see that working out, and how easily do you think it might be for physicians to do that, or do you have any insight into how that works or will work?
I don't think there is an exact procedure for opting out. I think the thing is that you just don't sign up for it.
You just don't take that coverage.
You have patients who are covered under an exchange plan. They're going to be under those regulations. There is a private market out there also.
Would you recommend having them sign a form or something like that? Because this is sort of a new experience here.
Well, what I would say is we have insurance. Private insurance hasn't gone away. I mean, United Healthcare is only going to do 12 different states in the exchange. Nobody has to go into the exchange. Nobody has to be covered at all, but they certainly don't have to go into the exchange. And so they don't have to opt out of the exchange, and a doctor doesn't have to participate. I think I would watch the contracts. Because if you're actually a contracted physician, they're likely to mention the exchange in there, and then you have a decision to make.
A contracted physician with
Yes, yeah.
Yeah, see, I don't have any contracts. I never ask patients, what insurance do you have? So I just treat them all like private patients. If they want to file a claim, they can, but they don't. But if you see me, you don't have to have a claim filed. If I had a contract with the insurance company or Medicaid or Medicare, a claim would have to be filed. And I think some patients go to see a doctor who's not involved simply because they don't want anybody to know that he even saw that particular doctor.
Which one's next, Jeremy? Over here? Okay,
Sorry.
Mr. Weber.
I have, by the way, I have some paperwork for opting out of the exchange in California, for a physician to opt out of the exchange, and I'll email that to you.
Please.
So that you have it. And I'm not, California was the first one to come up with it. I don't know what the other states will have, but I'll get that to you. And Twyla, if you want it, I can send it to you as well.
I would like to see it.
The question I was going to bring more of a kind of a statement is dovetailing on what Twyla was just saying. Medical Information Bureau, MIB, okay? identity theft, and I've written about this on Mediblog a couple of times. Financial identity theft, where they steal your government tracking number and credit card numbers, that's worth about $1.50 a hit. Medical identity theft is worth $50 a hit. Okay, very, very lucrative and dangerous. The same way that you can get an annual free credit report, you can also get an annual MIB report. And I encourage you to do that. If you Google Medical Information Bureau, it tells you how to do it. You can submit that form there just to see what's on, you know, whether somebody, you know, once gave you antidepressants and it's permanently on your record, because then later on, if you apply for disability insurance, you're declined because somebody once gave you an antidepressant. So it's very important to keep that.
Jeremy, over here.
For those of us physicians who are up to our ears with the insurance and want out, do you have something on a website or something that goes a step-by-step how to get out of all this?
We have step-by-step on how to opt out of Medicare, and we have many of the presentations that are at these seminars under apsonline.org/freedom. I think that we may have some of the handouts give a step-by-step thing, the one particularly from Dr. Berry about how he started his cash-based practice. It's in your folder, and that's linked to our website. We could certainly do more along that line, I think.
Question behind you? There's a couple right here.
Here. Thank you. Dr. Orient, I remember reading something from you or by you in the past talking about the fourth option, which is disenrolling from Medicare altogether. I came in kind of late today, so if somebody mentioned something on this earlier, I apologize for bringing it up again, but I wonder if you could comment on that briefly.
The brief comment is that everything I know about it is in the Journal of American Physicians and Surgeons, and if you look up, go to jpands.org or link to the journal from our website, and you can search my name or you can search Susan Hansen, Hansen, and we have gone over as many of the documents as we can find to update you on this. It's a gray area of the law. There is actual provision in the law for how to opt out. They don't really know what to do to people who just aren't in, except that there is a form you can check that you want to disenroll, and you can simply do that. Or you automatically get disenrolled if no claim has been filed for 12 months, which means, well, it's kind of crazy to have to re-opt out every 2 years then, isn't it? But I think the difference is if you're opted out, then your patient can be referred for an MRI or for a consult and get paid. Whereas if I refer them, that could be a problem, especially now. I've been disenrolled since 1990, and it's never caused me any problem, but occasionally I've had to get somebody else to co-sign for a patient to get a test.
Can I just add that I think that one of the things that has to happen is not only I mean, you're getting educated here, right? But you have to bring your patients along with. Patients have got to see a reason why it might be a really good idea for your doctor or for you to not be involved. They have to see what the danger is for them. I did write a report, just a one little pager, or I'm sorry, a 2-pager called Medicare Needs a Rescue Plan, an escape plan, not a rescue plan, because we need a future without Medicare. And people have to start to see why, and patients aren't thinking, but you're the doctor and you can help them. So whatever you can do to educate your patients on why they should actually want you to be free would be a good idea.
There.
First of all, thank you for all you do, both of you. That was, it's very inspirational to listen to you both. Is everybody here old enough to remember Logan's Run? Going into the exchange sounds like going on carousel. Where in a planned society, that's when they zap you at age 33. A little advice, many more states are adopting the reporting requirements, community reporting requirements that Minnesota has had now for 3-4 years. And I just wanted to tell people, if you do opt out, you can tell those people that are requiring you to report the way you manage certain conditions, where you have a numerator, which is the adherence to a practice guideline. The denominator is the number of people with that given diagnosis code. And every year in Minnesota, we have to report 3 or 4 diagnosis codes. So I applied for a letter of variance telling them that I really didn't think I had to do it. And they said, no, by law you do. And whether you're opted out or not. So I told them in a written correspondence that all of my numerators now and going forward are 0. So that all of my reporting algorithms are 0. And they said, well, you're going to get penalized. And I said, well, second prize is getting penalized twice. So and they never bothered me again for community reporting, for the report cards. So I have a 0. I wear it as a badge of honor. But in terms of practice guidelines and quality reporting, just tell them that your numerators are all 0.
I think that's an excellent idea. Thank you very much. I think maybe the penalty involves withholding part of the fee, and if you don't take their money, then so what?
I'm not quite sure what is the difference between disenrolling and opting out, and can you briefly explain what is the difference from the physician's viewpoint?
To opt out, you have to fill out an affidavit and send it in, and you have to have your patient sign a contract, and you have to do this every 2 years. If you disenroll, well, you just ignore them. But it's a gray area in the law, and they may threaten you with a $2,000 fine if they find out that you saw a patient without submitting a claim. But as far as I know, those threats have been empty. We're trying to find out more, but they're not responding to FOIA requests.
Any other questions? We've gone just a little bit over. I don't think anybody's unhappy with that. This has been an excellent, excellent program. The beautiful thing about programs and being an MC is it all ends when the MC runs out of things to say. So you are all dismissed. Oh, I just thought of one thing. If you really want to solve this problem, what you got to do is teach patients how to say, how much does that cost? And the way you do that is, well, if everybody in America owned our little book, my wife would be very happy. So take a little time at the bookstore, and there's some authors here who would be happy to sign their books if you want to get them. Thanks so much. God bless you. God bless the United States.